Hey everyone, welcome to another episode of the KLF Deep Dive. I'm here with Suzanne Kirkendall. You guys have seen her before on the podcast, as you may have known, and she is the CEO of Verilon, and she's doing some really exciting stuff. I've known Suzanne now, I want to say for several years at this point, probably about 4 or 5 years at minimum, and I've seen you rise all the way up the ranks to now going, I want to start my own business. And she's a successful entrepreneur who actually, and I find this, I'm very jealous of this. She teaches at Columbia, which is very nice and very fancy. But I'm going to let her introduce herself. And then we're going to talk hopefully about the role of behavioral science in medical affairs and how that differs from, say, commercial, and how that is sort of playing out in the world of AI. But before we get started, Suzanne, tell us a little bit about yourself.
Thank you. It's wonderful to be back. I remember we met at a virtual conference in COVID, and we were in one of the little breakout rooms where they put little pictures of your heads when we were trying to figure out how to do virtual conferences, and it stuck. And so we're real life friends now. So that's so fun. But yes, hi, I'm Suzanne Kirkendall. I'm the founder and CEO of Verilon, which is a consultancy focused on bridging the worlds of business and behavioral science. For those who aren't familiar with what behavioral science is, it's an umbrella term that refers to all of the fields that help us to understand why people do what they do using psychology, neuroscience, etc., and then to influence behavior effectively. So I bring that to the business world in lots of different ways that we can talk about, but my specialty for my whole career has been healthcare, starting in academic research on health communication and behavior change, moving into marketing, and more recently, consulting.
So you've been tackling some of these more interesting spaces that not everyone truly understands or truly knows how to negotiate. But the previous term that people used to use and maybe is not in favor anymore was the term nudging. How is behavioral science broader and bigger than nudging?
Yeah, so Nudge, the book, came out in 2008, the first edition, and it was co-authored by a wonderful duo of Cass Sunstein and Richard Thaler, and one of those men is a Nobel Prize winner, and it made it so popular. It made it something that people were finally hearing about for the first time, and it made a huge splash. So for that, that's wonderful to popularize the field. I'm all about it. However, nudging is defined as shaping the moment of decision to make the desired behavior the easiest possible behavior. So we're talking like, is the box below the sign up on the email form pre-checked for marketing, or is it not pre-checked for marketing? That decision, you're nudging in one direction or the other, right? So it can be that small. And that stuff works. It is very effective for lots of fun, interesting psychological reasons, but it is such a small part of the toolkit of the overall behavioral science umbrella. So it has a lot of value. It's easy to talk about. It's fun to give examples and case studies of because it's kind of cute. But it is a one tool in the bigger toolkit.
Now, it's interesting you use the term, you talk about nudging being a cute sort of tool. Who is usually the person, and I love the term, by the way, shaping the moment of decision. Who usually guides this moment? Is it sort of therapists? Because when I think behavioral science, I'm thinking like therapy. Is it therapists? Is it commercial people? Because again, they're the ones going, I want this button checked because it converts into a sale for me. Is it medical affairs? Is it someone else? What sort of decides whose realm that plays it?
This is a great question. It's a good thing to clarify early in the discussion, so I'm glad you brought it up. A lot of people hear behavioral science and think therapy. I actually just co-authored an article with a friend about this, that we need to rebrand the field so it's clearer about what we are and are not. I am nothing clinical, so I'm not a therapist. I'm not doing one-on-one therapy with anybody. This is not about trauma. Sorry. Another time. So behavioral science is more almost like, think about it like design or UX is kind of more common terms that I think people would have a better association with what this is. So who does it? unintentionally everyone. There's kind of a classic quote from that book, Nudge, that talks about there's no neutral choice environment. A really simple example is a cafeteria. Let's say the Google cafeteria at their offices. Somewhere there's going to be pizza and somewhere there's going to be salad. They could make that decision randomly, right? They could say, oh, we're just going to draw straws about where the pizza and the salad and everything else goes. That's a way you can make a choice. Is that the best way to make a choice like that? Probably not. They could put the pizza front and center. So it's the first thing you see and it's the easiest thing to grab on the way to the checkout. They could put it at the far back corner. So you have to go and hunt for it. And it's a little bit harder. There's a little bit of friction. All of those are choice architecture choices or nudge choices where you're making different behaviors easier or harder, just slightly, but that impacts what people choose. And so you could be a cafeteria manager, you could be a web designer, you could be a salesperson talking to people face to face. Anybody's creating moments of decision because we are always influencing each other in different ways. So I think it's actually our obligation to understand the ways in which we influence one another and use it responsibly.
So, I mean, I can think of like a million uses, and you and I have talked about a million uses of behavioral science. The part that pharma, for example, is always struggling with is the question of, well, how do we get patients to take their drugs? The multi-billion, if not trillion-dollar question. So if that's true, and many have tried, most all have failed. So what makes that question so difficult, and why have people had a hard time solving it?
Yeah, so medication adherence is a very tricky problem. This is what I started my academic research career in, was early text messaging studies for medication adherence, where folks were just randomized to a couple text messages a week of different reminders, and then saw at the end of it if it worked, and it did, and it ended up winning a Google Impact Award because text messaging for medication adherence at that time was novel and innovative. We've moved beyond that, but we still haven't really cracked the medication adherence problem, and it's still the case that about 50% of meds are not taken the way they should be, whether you're taking too much, too little, wrong time, stopping too early, et cetera, et cetera. There's lots of ways to do it wrong. And I think the big problem that we have, which does not take a behavioral science lens, is people assuming that it's just because people forget. You jump to thinking, oh, people forgot to take their pills, so we just need to remind them. And that'll solve the medication adherence problem. And it is so much more complex than that. There are so many different psychological factors, and they're so particular to the person as an individual, but also part of, the societal group that they're a part of, their culture, the type of medication, the type of disease, their relationship with their doctor. All of that stuff matters. And so it can get very complex very quickly. And if you don't have the right toolkit using the understanding of that health psychology, you have absolutely no hope.
So you said an interesting thing, and it's become almost anathema to talk about this, and we don't talk about diversity anymore. But you talked a little bit about culture. Mm-hmm. Why would culture play a role in whether you take the medication?
So there's lots of really different, interesting examples. One classic one is if you're part of a group that has been historically effectively abused by the medical system, you're probably less likely to trust the medical system, right?
Right.
Classic example is the Tuskegee study. We were experimenting on people without their consent, and it was very bad, right? So that's an example. Another example that's less about direct historical mistrust of the health system would be more cultural norms. For example, some cultures really, really prioritize for men being macho and strong and indestructible. And if that is your way of being in the world, the way that you have grown up your entire life being told is the correct way to be, it can feel to some people in some ways like you are admitting that you are not strong and indestructible if you got to take some meds, or you got to take your injection, or you got to admit that you even need to go to the doctor, right? And so you get all these kinds of things going on that can be really tricky to manage in the way that we usually approach this problem.
That is fascinating. I hadn't connected the macho thing in the same way. Now, the group within pharma that gets tasked with solving this, is obviously commercial because they want to sell, but also medical affairs because they're often responsible for making sure that scientific questions are answered and patients hopefully get better. They're not allowed to practice whatever profession they are. That's not the point there. Their goal there is more making sure that patients benefit and questions are answered and scientific discussion ensues. So why has why has there always been this interest from commercial, and what is the trend moving towards medical affairs?
Yeah. So at its heart, a lot of behavioral science overlaps with marketing. Not all of it, certainly, but marketing was an early user, right? And commercial does a lot of marketing because marketing is for sales, as you said. So it was just a natural place, right? We're trying to drive more scripts. That's selling. We use selling techniques, which are persuasion techniques, which when you use psychology, it's going to work better. So it totally makes sense. And I've worked at healthcare marketing agencies. I started the social science division at one large one. It is a great place for it, right? I've done a lot of that. In more recent years, medical affairs, which is honestly like a newer field in and of itself anyway, is starting to take notice of behavioral science. So I was just speaking at the Medical Affairs Professional Society US conference a few months ago in Denver about how to use behavioral science for insights, how to use it for training. And folks are so excited, which I love to see. I think people who go into medical affairs are, like me, science nerds, even more so than people who go into the commercial function, who are also definitely into the science, but it's a different thing. So when they hear behavioral science, they hear models, they hear theories, unlike most people, they get excited instead of having their eyes glaze over, which is a treat for me. So I get to nerd out with the folks who enjoy seeing constructs labeled in little diagrams about how people work. So it's really interesting. Folks are really in medical affairs also very concerned more and more and more. I'm hearing everybody talking about moving from measuring activity to measuring impact. And that is a huge challenge medical affairs is trying to crack right now. So historically, it's just measuring how many people did you call on? How many emails did you send? Because we're not measuring scripts, right? So what else are we going to measure? But everybody's in agreement, which is pretty common sense, but we still need to get there as a group, that just activity does not equate any kind of impact on making sure people are actually educated, on making sure the message is clear, et cetera, et cetera. And so there's a lot of discussion about impact. And of course, impact means some kind of change behavior. And so now it's a really wonderful time for medical affairs to turn more towards behavioral science as they're trying to evolve the field in that direction.
I feel like everyone talks about impact and sort of everyone's moving from I don't care how you do it, just get it done. Yep. Because in many ways, I'd argue AI has simplified or made people feel that it's been simplified. The process of getting it, of sort of what needs to be done, because AI can figure that out in the background. As long as you know what the output's supposed to be, you can check if the inputs and the processes were handled. My question for you is, from an impact perspective, what is the impact that behavioral science helps with for medical affairs? What are some of the outputs they've talked about that they value and they want to have addressed?
Yeah, so some of the things I'm exploring with folks right now, in fact, focus on how do we know that our education worked, right? Just because you showed up a certain number of times does not mean it sunk in. And so how do we start to measure that? There's already lots of interesting tools out there to monitor, for example, social media sentiment and messaging. So you can see, are these doctors in this specialty, what are they tweeting about? What are they talking about on LinkedIn, right? And see, are they getting it, first of all? Are they using language correctly? Are they saying they love it, they hate it? That's all information for us to be aware of. And that's a really simple thing you can start to track. So we start to say, what can we measure that's not literally giving them a test necessarily, right, to test knowledge, but how can we glean it from other hints? And that's one example.
So how can we glean it from other hints? I guess I'm trying to understand. You start off, you're essentially describing an observational study at that point. You're going, what do people, or real world evidence, if you will, in that we're not gonna like A/B test you or any of that stuff. We'll just see what happens. Um, Talk to me a little bit about you measure. You said measuring impact. What is an example of a situation you got called into, and how did you help address that problem? And how do you find yourself bringing the right stakeholders to help you see if you're addressing the problem?
Yeah. So a really simple one is actually to start closer to home with the field force, right? Before we even look outwards, we need to look inwards. And so looking at how are we training and equipping our medical science liaisons, or if you're in commercial, your sales reps, to be effective and impactful, especially in medical affairs. Now that we're not just measuring activity, we're measuring impact. So the quality and the nature of their engagements has a whole new level of potential that we can influence using behavioral science. So very simple techniques can make folks a lot more effective in face-to-face interactions. And I've worked with everybody from patient educators and call centers, just talking to patients on the phone all day about medical devices, to financial advisors for big banks working with uber wealthy clients and trying to get more effective communication there. And a lot of it comes down to remembering to put the human stuff back in. Because when folks are customer facing all day, they end up kind of just getting in their zone, doing their spiel. They have relationships, but they're not using the techniques consistently that one would use if you were trying to make sure that someone understood your message, or you're trying to make sure that they follow through on the thing that you guys agreed that they're going to do. And so that's a lot of what I do, is say, okay, what is supposed to be happening? What is actually happening? How do we make both of those things better using the behavioral science lens that people did not use when they created the original standards? And then how do we do the change management of that? Because one training is not going to do much for you. Within a week, we forget about 90% of anything that we learn in a training. So you need to make sure that any kind of change process comes with an understanding that you need to reinforce it in certain ways, with materials, with team check-ins, with the appropriate culture and process change, to help people actually implement what you want them to change going forward. And that's something a lot of people forget or do as an afterthought, and then they don't get their investment's worth.
So you said something interesting, which is, what is something that is happening versus something that you want to happen? Now, that sounds great in theory, because I think that a lot of pharma companies are like, what I'd like you to do is I'd like you to take my medication 4 times a day. Great. I don't think there are that many of those left, but the ideal drug is supposed to be 1 tablet once a day for the rest of your life. Allegedly, that's what everyone worked towards. That's what I was taught 20 years ago. The truth is, if you're forcing me to take the tablet 4 times a day, the problem's not in my taking it. The problem's in the way you formulated the tablet. Who wants to take a tablet 4 times a day? You're trying to cause a change. And the truth is, at a practical level, you're just never going to get it. So as a behavioral scientist, how often do you find yourself saying, yes, I understand why you want the change, but the problem's it's not in the behavior, the problem's in the product. And we need to redesign the product, not the behavior in this case.
Oh, yeah, often. I work, obviously mostly with pharma, but I've worked with lots of different consumer goods companies. And then obviously that's an easier conversation in many cases. We're talking about, chips or wipes versus ointments and injections. So absolutely, it's a conversation we can have. I tend not to go there with pharma clients because usually we can't do anything about it. But sure, there are cases where, for example, I worked on a topical ointment that was meant to be used twice a day. And it was better than the other options in that treatment area, but it was still an ointment you got to use twice a day. And it's, you're greasy in the morning, you're greasy when you go to bed. Not much we can do about it, right? I would love to make it just once a day if I could, but that's not where we're at. So then we say, okay, let's accept reality radically and work with it in detail to say, okay, how can we make the most of this and align reality with our desired behaviors as much as possible?
So we don't need to go into specifics, but what's a great solution that happened there where you went, Oh, so that's what we could do to manage this specific problem.
Sure. So in that case, in many cases like it, usually what you're trying to do, as with any behavior where you kind of feel the pain now but get the benefit later, could be exercising, could be eating healthy, etc. You try to bring some feeling of the benefit to that moment that you use it. Make it feel rewarding somehow. Even if it's not the long-term benefit or the real reason that someone takes it, you try to make it rewarding now. So, for example, if we haven't done this, but like an ideal example for that topical would be, okay, we can't change it to once a day, but can we make it smell nicer? If it smells nice, then it's more pleasant to use. And then it's like a lotion, and then I want to use it, right? Or you can do more education or other supporting resources around, what does this mean? How do I break down that long-term goal of the change I'm hoping for in my health that's going to come in probably months, right? And make it feel like this thing I'm doing this morning, this Tuesday morning, Wednesday morning, Thursday morning, etc. How do I make it feel like I'm connected to that value somehow? So there's lots of interesting different ways to do that depending on, is this a daily pill? Is this a weekly injection? Is this a twice a day appointment? But it's really about, how do I bring the faraway benefit closer?
So I'm going to go back about 15 years. The hot thing was to do gamification.
Yes.
And everyone talked about gamification, like, oh, you get points and you get this and you get that. I haven't heard gamification mentioned as much anymore. Is that because that technique doesn't work as well as we thought, or people have just moved on to the newest whatever tool it is, or it's still used and I just haven't seen it?
I think it's all of the above. I definitely still hear people talking about it. It definitely has a place. It's not the be all end all. But folks like it, I think, because it sounds fun. It's easy to understand. And intuitively, it feels like, oh, give people points, they'll do the thing we want, right? But again, this is more complex. And once you get into the psychology of incentives, things get really interesting. And that's really what we're doing with gamification. We're trying to, make it fun in the moment, which has its own value, but we're also trying to create some kind of point system or tiers or competition. And when you're getting into incentivizing behavior with some kind of external reward, like points, you need to tread very carefully. Whenever I'm designing any kind of behavior change intervention across any setting, I go to incentives last if I touch them at all, because there's so many other things you can change about the experience, the social norms, the process being easier, that probably are going to solve a lot of your issues that you don't need to go there. There's a great book that I would recommend called Mixed Signals by Yuri Nizi, which is all about lots of fun different stories of incentive design programs backfiring horribly. There are so many interesting ways they can go wrong, first of all. And second of all, when we're talking about long-term repetitive behaviors, incentives don't last. Right? If somebody paid you $5 every time you went to the gym, or even $20 every time you went to the gym, that'd be fun for like a week. And then you'd be like, hey, but I'm tired and Netflix is calling. And like, I'm kind of taking this $20 for granted. And you know what? I could skip it today. It's okay. Right? It wears off pretty quickly. So what we really want is for things that happen occasionally, like an annual flu shot, definitely give people their sticker and their lollipop, right? It's a one-off thing. I'm not trying to make it a habit in the same way that I'm trying to make a daily pill a habit. For something that occurs regularly, we really need to encourage more intrinsic motivation and just make it as easy as possible.
That's fascinating. So I can totally see gamification become a problem, because one of the things I had to deal with a different client was they were talking about, well, and then you get to take those points and then recoup them for something else, exchange them for something else. And there are legal rules that come into play with that exchange, in which I've always sort of gone, I hadn't even thought of that, but then it made me realize that the point system does come back to bite you every so often, so you need to be aware of it. How often do you find some of the stuff you're doing starting to impinge or impact things like sales? So if you do this right, you'll have an increase in sales or an increase in prescribing, and therefore the lawyers, the compliance people get involved and go, hey, you want to have a look at what you're doing. Or do you find that to be not an issue that's raised as often because they go, you guys in medical affairs figure this out?
To be fair, I'd say everything I've ever proposed that actually moved forward at any pharma company function, med legal was involved. So nobody's escaping, which is good. We want to keep people, safe and compliant.
Okay. Now, another element that I would sort of ask about is going back a few months. We used to have Facebook, used to be the big bad of the social media world. And they talked a lot about how they incentivize people to stay on the website. And I would argue that that's sort of where things like Zuckering came from, and the FTC came out and said, these are all dark patterns, you need to be aware of them. I imagine some of that had to do with why nudging had to be reviewed from a more broader perspective and said, look, there is that people who do that, but they're a small part and they're not the practitioners we're thinking of when we talk about the broader aspects of nudging. We're talking about things like changing how you take your drugs. The new world of that, the new version, I haven't heard Facebook's name in the big bads in a while. Now it's OpenAI, and how it's trying to give medical evidence. In the state of Pennsylvania, Josh Shapiro recently came out and said, you know what, I'm going to sue characters.ai because the AI is saying things and alleging that it is licensed as a medical doctor when it's not. So I guess my question for you is, and I'm sure you've seen this as well. You ask the AI a question, it answers the question, but always has a follow-up question for you, which to me is a type of behavioral nudge to go, keep engaging with me, stay on this platform. What has been your experience? Is that intentional? I imagine it is. And how can you prevent an AI taking the role of a medical device and trying to behave as a medical doctor without causing all the legal issues like kids committing suicide?
Yeah, no, it is the Wild West right now. It is fascinating to watch, and every day it's different. So it's a very, very interesting thing to keep an eye on, and very serious, obviously. So yes, I mean, it's pretty widely accepted that these are designed to keep you engaging with the tool. So that's why they're designed to be very sycophantic and people-pleasing at their baseline, because they want to make it nice, right? So that's what we talked about. Make the experience better. People will engage with the behavior you want them to engage in. We love being told we're smart or exceptional or, wow, what an insightful question, right? It always has some kind of comment like that, again, with the baseline programming. You can definitely play with the settings. You can change and give it some instructions that it should always interact with you in certain ways, but it's still imperfect. It's still kind of now and then at least tries to revert back to its baseline as a pleasing assistant. And so, of course, it should be something that's used with care. When it comes to providing medical advice, this is really, I mean, I'm also curious if you have any interesting thoughts here, but it is messy. On the one hand, let's talk mental health care versus rest of healthcare. Mental health care, we are woefully undersupplied with mental health care providers, humans, right? And there's a lot of people who would like mental care. And so this is a huge gap that I think AI can fill in the future to a degree. Not for super severe stuff, but I think for a lot of day-to-day kind of therapy interactions, a lot of people like texting with their therapist. That's been an option on a lot of therapy platforms for a long time. So there's space there for that to expand access, which would be using the AI for good, right? Of course, it needs to be designed carefully. There are lots of interesting projects and lots of interesting work being done on that front on how do we make this safe and consistent, being able to identify when it needs to flag and bring in a human, et cetera, but it's not there yet. So something to keep an eye on. I'm sure we will get there, but that's really interesting. For the rest of it, yeah, I mean, it used to be Dr. Google. Now I feel like it's Dr. Claude, where it's really quite interesting. And you hear all these outlier stories of, this man figured out the treatment for his super rare disease by putting the whole literature into the chat GPT and it was like, oh, do this combination of 3 obscure drugs and you'll be cured, and it worked, right? There's the occasional outlier, so everybody's like, holy moly, this can fix me, this is amazing. And it interacts with you in a way that your doctor does not have time for. Your doctor may not be that patient and warm as the chatbot. And so all of that, of course, makes sense that people are using it in that way, because especially for things like healthcare, which are very personal, it can be hard to talk to a human about some stuff. So I think it's all very natural that we're wanting to use it in the way that we are. But privacy is a huge issue right now. This is a private company. They can do whatever they want with your data, right? They could change policy any day. There's no real protection. And you don't know that the advice you're getting is good. And, all the caveats around using AI for anything are have somebody who knows their stuff check it, because it's going to sound confident about all of it, and some of it's going to be wrong. And if you don't know that field, you won't know which part is wrong. So it's tricky where you can see why people are using it, but it's not there yet.
So I'll comment on some of the stuff you had. The one thing I've found relating to the fact that AI tends to be sycophantic, I found myself sometimes going, I don't like the fact that it is sycophantic. I don't want to engage with you because you are. And I hear that a lot from a lot of people. So I wonder if there is a way to address this pushback of the sycophantic AI. And I don't see anyone trying to fix it. Is that because from a commercial standpoint, it is better to have sycophantic AI that just more people, even though people complain, they prefer it. And complaining is just a natural thing that all people do. So that's my first thought. My second thought, we talked about having guardrails. And I love the idea of that, except I don't know if you heard about this case. This guy was using Claude. He let it work in the background. Claude went, and he had like guardrails put in. Claude went and deleted his entire business. And when the guy asked Claude, "Why'd you do that?" There was like, "I specifically told you don't do this." I forget if it's Claude or ChatGPT or Gemini, whoever it was, but he said, "I've made a huge mistake. I shouldn't have done that." Well, yeah, but that doesn't solve my problem. So that, to me, the idea of it's bad enough to do that to someone's company, when you do that to someone's health, I start getting more worried, especially when it positions itself as such a good listener. In fact, there's data out there, and I'm sure you've seen that data, that says that people prefer AI as a listener compared to a person. And I think that that's a very, very emblematic of the problems we have as a society, where we're not good listeners. We want to engage. We want to get our point across. We're natural arguers, for lack of a better term. And that maybe drives people away. You raised the question of privacy. From a day-to-day privacy standpoint, I think there are multiple elements you need to start thinking about. For example, there are multiple cases where, number one, people were showing the conversations that they were having, that the AI was showing those conversations to people. They were produced in court. That's terrifying. You kind of sense, I thought, and I've never read the terms of conditions overall, but somehow in my head, it was like, as soon as I finish answering the question, that conversation's gone. It is not. It is there forever. And that's kind of interesting. You talked a little bit about, maybe AI will serve as the mental health professional of the future. I thought it was really interesting. There's some bills out there that that look at limiting the liability of these AI tools. I find it interesting because they were like, you know what, we'll agree to a max liability of $1 billion. That raises two separate questions to me. Number one, the fact that you think you can get $1 billion of liability, and more importantly, the fact that you think you can get more than $1 billion of liability, which is why you need a cap. And that worries me, because you're looking at so many debts. I mean, I was looking recently, there were at least 7 cases involving people committing suicide. And while there are those one-offs, like anything else, of people benefiting from the use of AI. I worry about the other side of that, which is all the people who are harmed as well. And there's no adverse event system that's tracking all of this. But having said all that, we usually aim for about 30, 35 minutes. We're past that at this point, and the conversation went so quickly. Suzanne, if people want to reach you, how can they reach you?
They can find me at my website, www.verelongroup.com. That's VERELON group.com. Or please find me on LinkedIn. I always love to connect and chat there.
Awesome. And this was amazing. Thank you all. If you are able to, feel free to go to her website. Again, this is Verelon Group. If you scan the QR code in the top left, you can see her. If you want to talk to her on LinkedIn, that's the QR code for LinkedIn. Sign up, talk to her. If you want to talk to me, this is the Kulkarni Law Firm, so you can actually talk to me as well. And I am really excited to have all of you. Hopefully, we'll have Suzanne back again if you guys like her. Feel free to reach out, and we'll talk soon. Thanks, guys.
Thank you.